Hi, this is Brian Kim. I want to share with you this case of a patient who had a dislocated IOL and the lens fell into the vitreous space and was on the retina. And so the retinal specialist did a vitrectomy, took the lens out, and this patient was referred for a secondary IOL placement. And so this is my modified Yamane technique using the Sensar AR40 lens, again, externalizing the leading haptic through a contralateral limbal incision. And, I really focus on the neutral position when you're going to place the needles through the sclera. And when I do the left side needle, before I was grabbing the main incision, it caused the eye to turn away. And so now I like to hold the contralateral incision with forceps. But in this case, because of the ergonomics and the logistics, I had poor access with the forceps. So you're going to see how I use the chopper to hook the contralateral incision so I can scleral fixate the left side. So this is the eye. You can see this patient's aphakic. You can see it's kind of a modest sized pupil. I make my ink mark on the right side and then the left side using the cannula to find 180 degrees apart for me. And these are the fixed calipers. I'm indenting the sclera 2.5 millimeters posterior to the limbus and 2 millimeters adjacent. Remember, you always have to use Wexel sponges to dry the surface completely. Using the fixed caliper on the left side again in similar fashion. Again, you have to dry, dry, dry. If you don't dry, you don't get those distinct marks. So you dry, 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 indent 2.5 millimeters posterior to that mark, and then 2 millimeters adjacent, and then dry, dry, dry. And then this is a 27 gauge cannula inked on the tip. Using the cotton tip, switching to the cotton tip, it's better to manipulate the eye with a cotton tip than the Wexel sponge. I make my contralateral limbal incision, and then this is the incision for the AC maintainer, and then this is my incision just for further manipulation. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium. Again, this patient's already been vitrectomized, so I'm not going to get the best coating. This is the 3 millimeter blade. Again, this is at right angles to the marks and 180 degrees away from the contralateral limbal incision. This is the cartridge for the AR40 lens. Push cohesive viscoelastic to fill the barrel and as well as on the platform, placing the lens on the platform, turning it into position, pushing down on the edges, making sure the optic edge is seated down. And then I'm going to bend the wings together, making sure the optic bends backward, concave, and then the leading haptic comes straight through the barrel and the trailing haptic comes out through the back. Place it into the injector, making sure the trailing haptic is sticking up and above the barrel. Advance with the plunger, and now you're ready to go. Placing the 22 gauge thin-walled AC maintainer with Epsilon. This is a great AC maintainer because it's thin and goes through a paracentesis, and it has good infusion because of the thin wall. This is a 25 gauge needle to externalize the leading haptic. This is the right side needle, bending it 9 millimeters from the tip, making sure the bevel faces towards the main incision. And this is the left side needle, bending it at the hub, making sure that the bevel faces towards the contralateral limbal incision. Placing the 25 gauge needle through the contralateral limbal incision, the bevel is facing the right. Placing the AR40 lens injector through the main incision, the bevel is facing the left. Both bevels are facing each other. My assistant will advance the lens, and as she does this, the leading haptic comes out. I ask her to stop, and then I'm able to dock the haptic on the bevel of the needle. I'm making sure I'm aligning the needle towards the haptic. She advances the lens. As the optic comes out, the haptic is internalized into the 25 gauge needle, and she keeps pushing and pushing and pushing. And then as I pull the 25 gauge needle out, the haptic is nice and out. So I switch and take over. I start to advance the optic into the anterior chamber, and then the trailing haptic is left outside. Pushing the optic down so it clears the AC maintainer, and then pulling the leading haptic out. Holding the main incision with the forceps, I'm going to stab the conjunctiva and sclera. And once I stab, then I turn on infusion. Turn on infusion now. I tunnel 2 millimeters, stay nice and flat, 2 millimeters, and then I dive down. Infusion was on while I was tunneling this needle through the sclera. Using smooth forceps, I slide the haptic into the incision without bending it. You saw how gentle that was. I dock the haptic on the bevel of the needle, and it goes right in. 2 pushes is all you need because this is nice, snug fit. Disengaging the needle from the syringe and letting the syringe fall. You can see that the optic falls down behind the pupil, which is fine. Internalize the leading haptic with microforceps. You can see how I'm more vertical with my location, and so I'm getting snagged by the nose of the patient, and I'm not able to use forceps to hold the contralateral limbal incision. So what am I going to do? I go ahead and place a chopper through the contralateral limbal incision as counterforce. Again, with the eye soft, I place the needle over the conjunctiva sclera, and then I turn water on. I stab through the conjunctiva sclera. I stay shallow. I tunnel to the other mark, 2 millimeters. And then I turn vertical, and then I dive down. I rotate the needle in front of me, take the chopper out. Again, I use a smooth microforceps to grab the leading haptic. Turn the needle towards the haptic, not the other way around. Turn the needle towards the haptic, dock the haptic on the bevel of the needle, flatten it out, making sure I'm aligning properly, and it goes right in. You can see there's some heme, so I must have nicked the ciliary body with the left side needle as I passed it. I tried to be nice and vertical. I tried to turn and dive down, but when I turned and rotated the needle, I must have been too shallow, nicking the ciliary body. So again, try not to do that. You want to stay, again, dive down towards the optic nerve and then rotate. You want to make sure you're nice and dry after you pull the needle out and you grasp the haptic, making sure it doesn't fall back. You want to make sure it's nice and dry, and then you cauterize. Do the same thing on the other side. You pull the left needle towards you, but the right needle you have to pull away from you because that's the direction it came. And then I have forceps ready to grab that haptic. Dry off the surface because a wet haptic cannot be cauterized. So you want to keep it dry, and then you cauterize the tip. You can see how nice and flat the haptics are. I push the haptics into the sclera. You want to push it nice and flush, deep, and then reapproximate the conjunctiva. And you can see perfect centration of this lens. Go ahead and place a tendo-nylon suture to close the main incision. And then I'm going to hydrate my incisions, and really that's the end of the case. Just going to hydrate my incisions now. Unfortunately, because I nicked that ciliary body, this patient did have a vitreous hemorrhage afterward, and that's always rather disappointing. You know, you do this well-executed surgery, and the patient's expecting to see well day one, and then all they see is just really, blurry. And so remember, when you turn that needle down, you want to make sure you're pointed towards the optic nerve. Of course, because of the way the needle is angled, sometimes it's a little bit of a challenge, but you want to be intentional about when you're tunneling 2 millimeters and then you rotate up, and then you turn that needle up, and then you dive straight down to the nerve, and then you rotate it, making sure you clear the ciliary body. Nonetheless, this patient did very well. I'm hydrating my incisions. I took the AC maintainer out, and you can see a well-executed, perfectly centered AR40 lens. Again, using the C2 Lucia has really been bad for a lot of surgeons. You're getting this propellering of the haptic within the optic. They've been getting vertical tilting of the lens optic. To me, that is really a big risk and an unnecessary risk for people to be using that lens in the context of a manufacturing issue. Don't put a potentially defective lens in the eye. Go ahead and switch to a different lens. And if you employ my techniques, you can utilize the Sensar lens and other PMMA haptic lenses without difficulty. So my latest pearl is, when you have trouble grasping the contralateral limbal incision to create counter-fixation when you're trying to stab the left side needle through the sclera, instead you can use another instrument like a chopper to hook the incision to keep it in the neutral position for counter-fixation when you're trying to tunnel the needle through the sclera on the left side. So I hope this was helpful to you, and I thank you for your attention.